Thank you very much for that lovely introduction. Yeah, I think Michael and I drew the short straw because not only do we stand between you and drinks, I have to follow Carl, and that's kind of an impossible task. I will do my best, however. So thank you very, very much, Eric, for the opportunity to be here and for the chance to talk about one of my very favourite topics, which is really all about genetic counselling and how it has the potential to really unlock the potential for... Oh, hello, what happened there? I don't know what happened there. Let's go back. To unlock the potential for the genomics revolution. So, very quick outline about what I'm going to talk about for you here. So first of all, I'm going to talk about the genomics revolution, specifically as it relates to the prevention of common complex disease. So we're going to talk about expectations that we've established for that whole thing, and then we're going to talk about the reality of where we're actually at. And then the second thing we're going to talk about is really about taking that theme and taking it further. So this idea of using genetic information as a motivator to engage people in behaviour change to reduce their risk for common disease really is one of the golden grails of genomic medicine. So we're going to talk about genetic counsellors' role in that. And then we're going to talk at... Oh, I don't know what's going on here. And then we're going to talk about... in the last part, we're going to talk about reconceptualizing genetic counselling. So quite literally, I want to walk us through rethinking everything that we think we know about what genetic counselling is, where it's delivered, and who it's for. So, not terribly much of a tall order there. So let's start at the beginning, because that's a good place to start. Where are we at with this whole genomics revolution as it relates to common complex disease prevention? So what you're looking at here, for those of you who are old enough to remember, this is a press release from the White House from 17 years ago, which is when, it makes me feel so old, which was when the first draft of the Human Genome Project was released. And the little red underlined bit is really just talking about how this is going to usher in a new era that will bring ways to prevent as well as diagnose, treat and cure disease, right? So this is from 17 years ago. Follow this up a couple of years, well, 15 years later, and then, Obama launches the Precision Medicine Initiative. And same year, Victor Zhao publishes an opinion piece in The Lancet, in which he talks, and this is a media release related to that, in which he talks about how precision medicine is going to save the US economy $600 billion over the next 50 years. And there's people snickering, for good reason, we'll get there. So how it's going to save this huge amount of money over the next 50 years, because we're going to be able to use genetic information to help people make behaviour changes to reduce their risk for common diseases, like heart disease. Sounds great, right? Yeah, it really does. And it's such a lovely idea that people have done lots and lots of studies. So... this is where we get to the reality part of where we're at in terms of genomic medicine. So I'm just going to flash up a couple of them here, but I'm going to finish with a couple of bangs. This is a Cochrane review from 2010, and this is from last year. This is a beautiful meta-analysis and systematic review of all of the studies that have tried to use genetic information as a way to engage people in behaviour changes to reduce their risk for common disease. And the upshot is that it doesn't really work, which is desperately disappointing because, again, like the economic potential here is enormous. The patient suffering, alleviation is really exciting here. But the reality is that this just hasn't worked. So this has led some commentators to suggest that, have you seen Gartner's hype cycle before? Well, here it is for those. I love it, frankly. But it's talking about when there's any sort of technology trigger, this is really what happens. And some people have been suggesting that we might be at that peak of inflated expectations when it comes to genomic medicine, particularly as it relates to prevention of common complex disease. And I do hate to bring the killjoy perspective, but Eric said to be controversial. So I'm just going to agree with that. So, but I am going to talk about how I think we can make it speedily to that beautiful plateau of productivity over there on the far right. So we're going to figure out how to get there by looking in detail at some of the problems, some of the assumptions underlying all of those studies we just looked at that have failed to provoke behaviour change by using genetic information. So some observations for you. The interventions in which the genetic information has been delivered in these studies has tended to involve a bunch of things. First, unidirectional transmission of information. That's what they're all founded on. Like somebody sitting there, healthcare provider or a researcher sitting there, blah, 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 fire hose information at a patient or a participant, and that's kind of it, right? So as well, little emphasis on linking the role that genetics plays in these conditions to the suggested risk reduction strategies, okay? And then last, little or no attention to emotion. So we're going to pick up on these things in a minute. But basically what we know about all of these studies is that they haven't worked, they don't provoke behavior change. This is common characteristics of these studies. Good. So that brings us nicely to my next point that I want to address, which is about how we can think about using genetic information to provoke behavior change to reduce risk for common disease. So I'm going to talk about this because I and my group have actually been having some success with making this happen. And I'm really going to sort of share with you what we've found. So basically, what we've been finding is that to get people to do this, to help them engage in those kind of healthy lifestyle behaviors to reduce their risk, we need to give them two things. We need to give them a sense of control. And that comes from having a coherent story that links for them the explanation for cause of illness together with the risk reduction strategies that we're suggesting. This sounds really obvious, and yet we haven't done it in all of these other studies, okay? And then the other part that we need to do is to give them an opportunity to address their emotions. So emotions, as you will see in a second, can act as a really profound barrier to behavior change. So basically what I'm going to do with you now is I'm going to walk you through how it can work by sharing with you a case example from my own practice as a genetic counsellor. So, and it's about somebody we'll call Jane, and Jane is actually a composite of a couple of people, but the principles are right there. So, Jane. So Jane was 50. She had a diagnosis of bipolar disorder. She had a job that she absolutely loved and that she was really good at. The problem was, however, that she was having to take lots of time off of her work because she was having episodes of depression. Her mental health wasn't great, let's say. The reason that she came to meet with me as a genetic counsellor is because she was really concerned about her daughter. She herself had developed bipolar at 21. Her daughter just turned 21. So in her words, she was waiting for it to happen to her daughter any day now. So as a genetic counsellor, my fundamental question that I always ask people at the beginning of a session is, can you tell me what you understand to be the cause of the illness that you have? And when I asked Jane, she just said genetics. I was like, anything else? She was like, nope, hurry up, lady. I'm here because this is genetics, move on. So I tried a different tack and I asked her to tell me about what was going on for her around the time that she first got sick. And she was able to list this whole slew of really awful, stressful life events that, but that she hadn't associated them, though, with having anything to do with the onset of the illness. So I talked with Jane about what we know from research about how mental illness does arise. And this is a model that we've developed by working with people who live with bipolar disorder and other mental illnesses and their family members. The idea is that we all have a mental illness jar. In order to be actively experiencing an episode of illness, the jar has to be filled up to the top. You can fill it up with these two different types of vulnerability factors, genetic and environmental. So I worked through this with Jane, showing her how her own stressful life events would have contributed to the vulnerability in her jar. I had to work really hard to get her to hear this, like really hard. And when it finally sank in, her reaction, she was horrified. She said that if she'd known it was anything other than just genetics, she would not be okay with anybody knowing that she had bipolar for fear that they would blame her. So I had, again, so this was an opportunity for me to work with her around, counselling around this shame and this fear and the stuff that was going on there. And I also talked with her about how those things that she'd experienced, those life events, were really nothing that she could justifiably be blamed for. So, some real counselling stuff around there. It also turned out that aside from taking medication, she really wasn't doing terribly much to take care of her mental health. So this is where the next part of our little model comes in. So we talked about the research evidence showing that sleep, nutrition, exercise, good social support and so on can all be really helpful, and perhaps by using some of these strategies together with her medication, she might be doing better with her mental health. So the idea here with the rings is that they're just stacking on top of the jar to make it taller so it can accommodate more of this environmental stuff without getting full, essentially. So we talked about that. And at one point, so we also talked about this jar in terms of what it meant for her daughter. It means that it's not a foregone conclusion that her daughter will develop mental illness and that she can employ some of these protective factors. So at one point, through tears, Jane told me, if we'd known it was anything other than just genetic, we would have had more children. So there's some fairly, heavy-duty emotional stuff going on there. 1 month later, though, Jane actually had a psychiatrist for the first time and was trying a new medicine that already seemed to be helping her better than the lithium that she'd been previously taking had. She was working really hard to get better quality sleep. She was going for a walk every day and she was eating more healthily. She'd lost 5 kilograms by the end of that first month. And she'd started mindfulness meditation classes with her daughter. So what you're seeing here is that she was able to use the information I gave her in the context of genetic counselling to change her behaviour, to help reduce her daughter's risk, and to manage her own mental health better for the future. And just to really drive this home, to do this, she needed to have these two things. First, she needed that sense of control, right? She needed that coherent link between explanation for cause of illness and the risk reduction strategies we were suggesting. So initially, she'd thought her condition was entirely genetic, right? So the only risk reduction strategy that made sense for her for relapse was medication. So in order to sort of engage her in these other things, she had to understand that that her condition wasn't entirely genetically determined. The genetics had to be contextualized for her, okay? The second thing was that we really had to acknowledge and address her emotions. In order to see that there were things that she could do to help her mental health, she had to accept a new model for explanation of her illness. And that meant confronting the regret of not having had more children and the fear of vulnerability of others' judgment, basically. So there's some heavy emotional stuff there. The counselling component of the genetic counselling is absolutely key. And that takes us very nicely, hopefully, to reconceptualizing genetic counselling and what we imagine it all is. Okay. So, yeah, okay, there's a thing I'm going to come back to maybe at the end if I have any time. So let's talk about this reconceptualizing genetic counselling, though, piece for now. So I'm going to talk about we need to rethink what it is, we need to rethink where it's delivered, and we really need to rethink who has access to it. So, you know, not terribly much. But let's take each piece in turn. Let's start with the what it is component. So we tend to think about genetic counselling as being an educational intervention, right? We tend to think of it as being information only. And of course, there's an educational component to it. We can help people to better understand cause of illness, chances for recurrence, and we can help people understand things that they can do to protect their health going forward. But of course, there's this counselling component. We also help with supportive, and we do the uncovering and addressing the guilt, shame, fear, stigma stuff, which is so important to Jane's story and helping her make those behavioural changes. We also think of genetic counselling as being for people who have, you know, some of these characteristics. And of course, genetic counselling can be helpful for those people, but it can also be helpful for other people besides. Jane doesn't easily fit into one of those categories, for example. Another issue is that we tend to think about genetic counselling as being an activity. And what I mean by that is we tend to think that if we're having any healthcare provider is having a conversation with a patient about genetic testing or about chance for kids to be affected, we think, well, that's genetic counselling, right? Nuh-uh. To me, that's analogous to saying that if I've consulted WebMD, I'm being a physician, basically. Just going to call it. So let me say what I so basically, it doesn't matter if you're having an interaction that involves talking about genetic testing, even if you're using those lovely jar model pictures that I just showed you, it doesn't mean you're doing genetic counselling. And let me try and explain why. So genetic counselling is actually a profession. So that's been around for about 50 years now. There's about 4,000 of us in North America, and we're growing rapidly. So, and this is how, as a profession, we've defined genetic counselling. It's a process of helping people to understand very nice information and adapt. That right there, that's something else, right? That's the counselling piece. To the medical, psychological, and familial implications of genetic contributions to disease. Lovely. To me, this definition fits beautifully underneath the umbrella of psychotherapy. Okay? Let's look at how psychotherapy is defined. And this is from the American Psychological Association. Psychotherapy is the informed and intentional application of clinical methods for the purpose of assisting people to modify their behaviors, cognitions, emotions, and/or other personal characteristics in directions that the participants deem desirable. Doesn't really roll off the tongue, but hopefully you can agree with me that that first definition fits beautifully underneath that second one. And I think that hopefully the story I shared with you about Jane, you can see how those ideas fit together. So, genetic counselling, not educational/informational only, it's psychotherapeutic. If it's done properly and if it's done well, this is what it should be looking like. So that's the what it is piece that I asked us to reconsider. So what about the thing about where it's delivered? Let's talk about that briefly. So genetic counselling has historically been a tertiary care service, right? We've been siloed away in these academic medical centres, basically. And in order to get to see us, you have to have a referral from a GP or from a specialist or what have you. But to reap its full benefits, we really need to rethink that. I think that we need to be integrating genetic counsellors throughout all disciplines of medicine, including primary care. I like to imagine a future where we have, as genome sequencing becomes more commonplace, we end up in a place where we all have a family genetic counsellor in the same way that we have a family physician. So this is important. This integration of genetic counsellors throughout all disciplines of medicine is so important because we know that physicians self-report feeling uncomfortable and unprepared to integrate genomic medicine into their practice. I mean, outside of clinical geneticists, obviously. But oncologists and so on feel very, very unprepared for this stuff. So genetic counsellors can help in a number of ways. First, and most obviously, perhaps, by helping to choose the most appropriate genetic test, technology, or lab in each specific context. And we actually have some beautiful data about the economic impact of engaging genetic counsellors in genetic testing decisions. And I'm going to share some of that with you right now. So first, Priority Health actually mandated independent genetic counselling review of testing, which saved over $10 million worth of inappropriate tests. So once you take out the $2 million plus little amount for genetic counselling itself, the savings were over $7 million. Study 1. Study 2, ARUP did a beautiful study. It's a bit of a seminal thing in our field now, where they had a genetic counsellor review test requisition orders, which saved an average of $36,500 a month. Right? And last of all, NSGC, the association of which I was president last year, commissioned Dobson and Devanzo, which is an independent consulting company, to look at the impact if Medicare were to recognise genetic counsellors as independent providers. And what that study found was that through doing that, Medicare could save over $4 billion over 10 years because of improved utilisation of genetic services. This is impactful stuff. Anyway, so that's only part 1. Part 2. So obviously genetic counsellors can help patients grasp the pros and cons of testing, prepare for and act on results as well. And then as you've seen through my story about Jane, we can help patients to engage in behaviour changes that could reduce their risk for common complex disease. And I'm just going to finish with a parting shot across the bow about who has access to genetic counselling. And specifically what I'm thinking about here is triage models. So it's really important to be aware that our triage models for genetic counselling have historically focused, well, they do still today. They're based on risk quantification. So we basically classify patients as being at higher or lower risk numerically. And we say that if you're at higher risk, then sure, you can meet with a genetic counsellor. And if you're not, then too bad, so sad, not for you. So we need to acknowledge, I think, that this is two things. First of all, it's very simplistic, like it's easy to execute this kind of stratification, this kind of triage model. But B, it's not centered around patient needs, right? So there's actually no evidence at all that this is the best model, either for patient outcomes or for cost. Very, very brief example. You can imagine that somebody who has an extremely strong family history of breast cancer and who would therefore be stratified into you can go and see a genetic counsellor may not need it at all. Maybe she's been raised in a family where they know exactly what breast cancer looks like, and she's got so much support around her. She knows exactly what the testing looks like. She knows what she's going to do because she's been thinking about it for ages, and she's got lots of support around what decisions to make. But somebody who doesn't have that family experience, and maybe who would be classified as being at lower risk and therefore ineligible for our services, might be really, really anxious, and we could actually do something really meaningful and powerful for that person. So yeah, just as a dig, we need to rethink our triage models, I think. Oh, and I'm over, so I'm going to finish there. So just to quickly summarise, because I did lots of things in 20 minutes, as we've seen, genetic information alone is not enough to get people to change their behaviour. But by addressing emotions and providing a sense of control, genetic counselling, with the emphasis on the counselling, can lead to behaviour change. Genetic counselling is not informational educational alone, it's psychotherapeutic if done properly. And genetic counsellors really do need to be integrated throughout medicine medicine, including primary care, we need to rethink triage models. I may have mentioned that. And I'm just going to leave you with a picture of my fantastic team, about 50% of who are pregnant in this photo. They've all now had babies, but there's another pregnant one. So, yes. But yeah, we didn't really touch on the work that we do as well. We did a little, alluded to. So this fantastic team is really the powerhouse behind our work on translating what we know about psychiatric genetics into clinical practice. So yes, thank you to them.